In this week's video I talk about tendinosis or tendinopathy of the rotator cuff tendons and with a focus on the supraspinatus tendon. Before we dive into the cases and the differential diagnosis of tendinopathy, just a few things. First of all, the term tendinopathy is composed of two different words, tendon and pathology, and therefore means just any pathology of the tendon. So it's not a very specific term, and that's why some people prefer the term tendinosis rather than tendinopathy. Another thing is that tendinopathy or tendinosis is sometimes more of a feeling rather than an objective finding on an MRI image, and you can see this also here in this study and in this illustration or graph here, where 3 different radiologists assessed the supraspinatus tendon in elite swimmers for tendinopathy and graded it into 4 different grades. You can see some patients, radiologists graded the tendon as severe tendinopathy, while the others said that it's just a normal tendon. So the agreement for tendinopathy between different radiologists can be vastly different. And on the other hand, each radiologist by himself was quite consistent, as you can see in this graph now. And that means that everybody has his or her own calibration for tendinopathy, and that's what I mean, that it's probably more of a feeling. So I myself, I'm more on the careful side, so tendinopathy is not something that I tend to write lightly. I have few criteria that we go through right now. Before we do that, just a quick shout out to my newest patron, Matas. Hi, thanks for your support, and also thanks a lot to all the other guys that are continuing with their support for my YouTube channel. And if you want to know more about how you can support this channel and what benefits you get, you'll find the link somewhere down here below. And with that, let's start. So this is the first case, and if you don't agree with my judgment, basically you just have a different calibration, which is completely fine and understandable. So I just give you my approach here with the risk of maybe having a different opinion than some of you guys, but that's not the problem. So this is just a young patient born in 1982, so he's 30 something years old, and we can see here this is anteriorly, this is the long head of the biceps tendon, and if we scroll posteriorly now, we can see here the first facet, the anterior facet with the supraspinatus tendon inserting here. Tendon looks fine on this proton density weighted sequence with low signal intensity. So now if we go further posteriorly, at some point we start to see some signal changes here in the mid-substance of this tendon, and now this is a point where we should be really careful to call this tendinopathy, and let me show you why. So let me begin in anterior position again, going posteriorly. You can see this hyper intense signal changes here, and we have like 2 different layers. What that actually is a slight overlap between the infraspinatus tendon and the supraspinatus tendon. So this is now posteriorly, and you can appreciate the infraspinatus tendons or slips coming here. This is still infraspinatus tendon, and they are overlapping here with a portion of the supraspinatus tendon, and this is just supraspinatus tendon. And this is infraspinatus and this is supraspinatus. So we have a slight overlap, and these signal changes in between should not be called tendinopathy. We can also see this on a sagittal, on a proton density weighted sequence. This is anteriorly, subscapularis, supraspinatus, infraspinatus, and we scroll anteriorly. We can see here this is the infraspinatus tendon blade and this is the supraspinatus tendon blade. And they already have some overlap here. And it's not well depicted here, we might see better examples, but you can see here all this orientation of these fibers. I'm not sure if you can really see it on the video, but they are oriented slightly posteriorly. So this is still infraspinatus here, insertion here. So the infraspinatus reaches far anteriorly, as you can see here, and therefore we have this overlap with this most posterior tendon fibers of the supraspinatus tendon. This is also nicely illustrated here in this publication, and I put the link to this paper on ResearchGate in the description down below. So let's go to the images here, and you can see here on an anatomical specimen that we have the infraspinatus insertion and the supraspinatus insertion, and that there we have a little triangle which is reaching pretty far anteriorly. It's even better depicted here on this graph here. You can see this broad insertion of the infraspinatus tendon with the most anterior tendon fibers here having an overlap with the anterior facet where the supraspinatus tendon is inserting. So, and in between these two layers we can have signal changes that are not tendinopathy. So here again, in a proton density weighted sequence in a young patient, 1994, we have some signal changes here in the supraspinatus tendon, which I wouldn't rate as tendinopathy at this location. And let's go anteriorly. This is the long head of the biceps tendon. Going posteriorly, we see a otherwise normal tendon. And if we scroll posteriorly, we start to see here a slight signal change, which is now the crossing or the overlap between the supraspinatus and the infraspinatus tendon, as you can see if we scroll further back. So this one here is already infraspinatus tendon, which is then overlapping here portions of the supraspinatus tendon, as you can really nicely see here. Now, if we scroll posteriorly, we can see some changes here. Now the question is, what is that? And therefore I urge you to always have a look also on your sagittals, and we can do that right here. So this is anteriorly, this is posteriorly, supraspinatus, infraspinatus, and now we scroll from the joint to the lateral aspect here, and we can appreciate the supraspinatus tendon and the slightly other oriented infraspinatus fibers. This one is still supraspinatus, and the infraspinatus will now overlap this portion here up to this point, probably here. And the signal changes that we saw are further in the back. So we have some signal changes here which are not fluid isointense, so but they are not normal. So this would be a mild tendinopathy for me, because the location, it's in the posterior portion of the infraspinatus and not at the level of the overlap. So it's important to also look on your sagittal images as well. And this is just the same patient with a non-fat set PD. Starting anteriorly, we have the supraspinatus tendon. Going posteriorly, here is the crossing, but this is too far in the back, so for me this is a mild tendinosis. So this one here is a nearly 70 years old patient, and in older patients people tend to write tendinopathy just because of age. But look at this tendon here. It looks normal here in the front. This is the anterior facet of the supraspinatus tendon. Then we have the overlap, a little bit of signal here, which is probably due to the overlap. But if I scroll through, otherwise the tendon looks normal. We don't have a thickening of the tendon, and even the signal, I would just rate this as a normal tendon. I can also show you a T1 here on a sagittal. And in case you're wondering why I didn't show you T1 weighted images beforehand, because not all of these exams had a T1 included in their protocol. So we can see we have the tendon here quite normal, no abnormal signal intensity here. So I would just say, even in a 70-year-old patient in this case, that we have a normal tendon without tendinopathy. Now here a roughly 60-year-old patient, and this is again anteriorly subscapularis, long head of the biceps tendon, and here we have the supraspinatus tendon. And if we scroll posteriorly, we can see the signal in the tendon is quite busy. We have these hypointense aspects, and then we have some hyperintense stuff around it. And we also need to have a look at our fat saturated images in this case. So here very bright signal, then here bright signal, then here the darker aspects, a little bit of bone marrow edema, and a tiny probably tear here at this site with adjacent bursitis. Now this is a typical differential diagnosis that you should have in mind, because this here is actually calcifications, and in this specific patient hydroxyapatite, as you can also see on the radiograph here. So we have to be careful not to call tendinosis when in fact it's just a calcific tendinitis. Here with breach of the calcifications into the subdeltoid bursa here, as you can see here, making a inflammation of the bursa with corresponding bursitis. So I don't want to bore you with even more cases because, as I said, it's a very personal diagnosis, and you might have a different calibration, but it doesn't really matter. You can always say tendinopathy, you will be never wrong, nobody can actually prove you wrong. either, because if there is no other indication to do surgery, nobody will ever know whether it's correct or not. So just find your own calibration and have at least a calcific tendinitis as a differential diagnosis in your mind. And with that, I'd like to thank you. Stay safe even during the corona crisis, and I hope you're all well, and come back next week for the next video. See you next time.